Hello, everyone. This is Dr. Mickey. I'm presenting and recording the lecture on Chapter 39, which is Allergic Rhinitis and Common Cold, and also as well we added the pneumonia to this chapter. So I'm going to skip a few slides at the beginning of the outset of these slides because that's an EMP, anatomy and physiology. So that's had been covered and known from other courses or previous courses. So let's start with these two questions, which the first one asks about, both of them, they're like definitions. The first one is the definition of orthopnea. And the second question, defining what is cyanosis. So as we look at the dyspnea, often dyspnea is described as breathlessness, air hunger, or shortness of breath. We always call it, when the patient is dyspneic, because they have ESOB or shortness of breath. The dyspnea and exertion, which is common to many pulmonary disorders. So I'm trying to cover all the signs and symptoms of most of these pulmonary diseases. They kind of tend to, patients with these pulmonary disease, they tend to have some similarities or common manifestations. So the dyspnea, pulmonary congestion, sometimes secondary to the cardiac or heart disease. That's usually the first cause. Because of cardiac disease, they become dyspneic, they have pulmonary congestion, like pulmonary edema, and then that would be the cause of this DOE. The orthopnea, which is dyspnea when a person is lying down, the horizontal position redistribute the body water, so that will cause the abdominal contents to exert pressure on the diaphragm and decrease the efficiency of the respiratory muscles. And that's why the patient become or exhibit this orthopnea. Like that explains why patients during sleep or nighttime, they prefer to, like patients with COPD, for example, or patients with CHF, they prefer to sleep on the couch or on the recliner, like sitting up. So the forward or semi-forward position or sitting up, that would be the most preferred position for these patients, because they experience the shortness of breath and dyspnea when they are in recumbent or supine positions. We have other forms of the abnormalities in terms of the breathing patterns. We have the first one is Kussmaul respirations. And this is very common in patients with DKA, which was, the one we just covered on Thursday in class. And it's characterized by increased ventilatory rate, very large tidal volume, and there is no expiratory pause. So that's how we describe this Kussmaul respirations. Chine-Stokes respirations, which result from any condition that will slow the blood flow to the brain stem, which will in turn slow the impulses sending information to the respiratory centers of the brain stem. The neurologic impairment above the brain stem usually is the contributing factor for this specific abnormality of respiration called Chine-Stokes respirations, which is the neurologic impairment above the brain stem. It's usually the cause or the contributing factor for this Chine-Stokes respirations. The hypoventilation, which is inadequate alveolar ventilation in relation to the metabolic demands. That will occur when the minute volume is reduced. So the minute volume is reduced, which is usually is caused by the alteration in pulmonary mechanisms or alteration in the neurologic control of breathing. The hypercapnia, which is the increased level of CO2, carbon dioxide, increase the blood, that is called hypercapnia. Hyperventilation, the hypocapnia is usually caused by severe anxiety, acute head trauma, traumatic brain injury, TBI, pain experience, in response to conditions that cause hypoxemia. And we can determine the hypo or hypercapnia, so in other words, can be measured by doing the ABGs. What is hyperventilation and what is hyperventilation and how does it affect blood pH? So the hyperventilation, that is breathing too fast, so we blow off too much carbon dioxide, and then our pH will rise. This will cause changes in the brain that can cause fainting or dizziness. Cyanosis, which is the bluish discoloration of the skin and mucous membranes caused by increased amount of desaturated, or in other words, reduced hemoglobin. So this cyanosis will occur or take place when 5 grams of hemoglobin is desaturated, regardless of the hemoglobin concentration. So it's all about the desaturation of the hemoglobin, more than just the concentration of the hemoglobin, and which is usually caused by any of these factors: decreased PaO2, pulmonary or cardiac right to left side shunts, decreased cardiac output, cold environment, anxiety. So what is peripheral cyanosis? Peripheral cyanosis is a slow blood circulation in fingers and toes, which is the periphery, which is most often caused by poor circulation resulting from intense peripheral vasoconstriction, such as that observed in people who have like Raynaud's disease, people who been outdoors in cold environments, severely cold weather, severely stressed conditions. So stress also can result in vasoconstriction as well. Clubbing, which is the selective bulbous enlargement of the distal segment of the digit, which is finger or toe, which is usually most affects the fingers more than others, but both are affected. It's not associated with any pain experience. It can sometimes be seen in individuals who have lung cancer, even without hypoxemia. And that's because of the effect of the inflammatory cytokines and the growth factors, which will result in hypertrophic, or what is called, we call this hypertrophic osteoarthropathy. Hypertrophic osteoarthropathy. And it's associated with diseases that cause chronic hypoxemia. So anytime you see this clubbing, you always associate with this clubbing with as a manifestation with chronic hypoxemia, and it takes time to develop. It takes, I would say, if not months, it takes years to develop this clubbing as manifestation of a respiratory disease or pulmonary disease. So patients who would develop chronic hypoxemia, like lung cancer, bronchiectasis, cystic fibrosis, pulmonary fibrosis, lung abscess, and also you can add congenital heart disease. Now the cough, which is either acute or chronic, the acute would or may result from upper respiratory tract infections, allergic rhinitis, acute bronchitis, pneumonia, CHF, pulmonary embolism. Also, you can add aspiration to that. So cough will be one of the signs on the patient when the people aspirate because of difficult swallowing, for example, and they eventually develop pneumonia from that. Chronic cough, which is more persistent or persists more than 3 weeks, that becomes chronic, and that will be in non-smokers, would result from the post-nasal drainage syndrome, or due to asthma, or patients with gastric esophageal reflux disease, GERD. And the smokers would be from like people who have chronic bronchitis. Sometimes, it's chronic cough. We have to rule out lung cancer, so we have to investigate and assess the patient for further testing to rule out the lung cancer. What would cause a person to cough? This is usually due to the mucus or fluids accumulate in the lower respiratory tract due to the inhalation of the irritating substances, lung tumors, pulmonary edema. So this is that's due to the mucus or fluids accumulating in the lower respiratory tract due to the inhalation of irritating substances or lung tumors or pulmonary edema. Hemoptysis, which is when we coughing up of blood or blood secretions, cough with blood. So the hemoptysis and hematemesis, the difference between them is that hemoptysis, hematemesis, that's when there's vomiting. Hemoptysis, cough, like patients with TB, for example, pulmonary TB, they have hemoptysis. They cough with blood-tinged secretions. So hemoptysis with blood bright red, alkaline pH mixed with frothy sputum. Hematemesis, that's usually blood is dark, acidic pH, because that's coming from vomiting. That's coming from the stomach. Acidic pH mixed with food particles. That's hematemesis. That's vomiting with blood, which is vomitus with blood. So it indicates the localized infection or inflammation. And these are some of the conditions that will can associate or which are associated with this hemoptysis. The abnormal sputum, which can be tested in the lab, like with patients, we can check for AFB, acid-fast bacillus, right, for patients who have, to rule out the TB. And then pain, we have different types of pain, like pleural friction, that will result in pleural pain. That's usually the patient will have, experience that pain when they inhale, not the exhalation, when they get, air in the lungs, inhale, they will feel that pleural friction pain. Hypercapnia, which is due to the hypoventilation, so they will retain CO2. Hypoxemia versus hypoxia. So the most common cause is shunting, which is the mismatch of VQ ratio, which is the ventilation perfusion ratio. V, ventilation, Q is perfusion. Shunting would occur in atelectasis, asthma secondary to the bronchoconstriction, pulmonary edema, pneumonia, in which that the alveoli would be filled out with fluids, so they will make like a barrier for gases to exchange between the blood capillaries or blood vessels and capillaries and the alveoli, and then they are right to left shunts, which would take place when or occur when blood passes through portions of pulmonary capillary bed, which is blood vessels in the lungs, that receive no ventilation. So the blood would pass through these vascular places in the lungs that receive no ventilation, which would result in decreased PaO2 and hypoxemia. So the hypoxemia, which is the reduced oxygenation of the arterial blood, reduced PaO2, that is usually caused by the respiratory alterations. However, the hypoxia, which is the reduced oxygenation of cells and tissues. So that hypoxemia, they reduce oxygenation of arterial blood, reduce PaO2. Hypoxia, it's more of a reduction of the oxygenation of the cells and the tissues, and that may be caused by alterations of other systems as well. So although that the hypoxemia can lead to tissue hypoxia can result from other abnormalities unrelated to alterations of pulmonary function, such as low cardiac output or cyanide poisoning. Hypoxemia, so we have alveolar dead space, an area with or where the alveoli are ventilated but not perfused. So we have good ventilation but no good perfusion. The most common cause of this, in which that there is a high VQ ratio, ventilation perfusion ratio, ventilation, how much air gets into the trachea and the alveoli, and then the perfusion, how much the blood exchange between these capillaries and the alveoli. So the most common cause of this, of the alveolar dead space, is the pulmonary embolism that will impair the blood flow to some segments of the lung. So when an area of the lung becomes hypoxic, the blood vessels supplying that area would constrict, so that blood can be sent to a part of the lung where there is more oxygen. This is the opposite of what would happen elsewhere in the body. So this specific phenomenon in the lungs is completely opposite to what we would expect in other or elsewhere in the body. In terms of that, when an area of the lung becomes hypoxic, the blood vessels supplying that area constrict, so that the blood can be sent to the part of the lung where there is more oxygen. Control of pulmonary circulation. So we have hypoxic pulmonary vasoconstriction, caused usually by low alveolar PaO2. Blood is shunted to other well-ventilated portions of the lungs, provide better ventilation and perfusion matching, which is a VQ ratio. If the hypoxia affects all segments of the lungs, then the vasoconstriction can result in pulmonary hypertension. So let's start with allergic rhinitis. So this is the pathophysiology, in which the patient would have a sneezing, nasal itching, or congestion, post-nasal drip. So the post-nasal drip occurs when the mucus flows backwards down to the throat, so that just one of the factors associated with the allergic rhinitis. Patient will experience that cough, in addition to the tearing, red, swollen, itchy eyes. They will have the sneezing, nasal itching or congestion, post-nasal drip, cough, scratchy throat, and some patients, they all tend to develop conjunctivitis, inflammation of the sinuses, sinusitis, asthma sometimes, become asthmatic, and so this is usually mediated by the inflammatory mediators, the release of chemical or inflammatory mediators like cytokines, leukotrienes, and others, and histamine mainly, the main one, histamine, prostaglandins as well. So allergic rhinitis. The most common causes are the pollens from the weeds, grasses, and trees. Sometimes it's the mold spores, mold, dust mites, certain type of foods also. Patient may develop that allergic rhinitis towards to animal dander as well. Very similar to the factors or allergens that trigger the asthmatic attacks. And this is the inflammatory response in which the first exposure and second exposure that we explained in class a few weeks ago under the inflammation and the inflammatory process, and how is the histamine. First, the mast cell becomes sensitized, and then anytime the first exposure, and then the second exposure, anytime the mast cell, the sensitized one that has the antibodies attached to it, anytime that becomes like in contact with this allergen or this factor, which is the allergen like pollen or the type of food, or then that's or animal dander, that will elicit the inflammatory response, and that's when the histamine and other chemical mediators will be released in the bloodstream and cause all these symptoms like the intravascular compartment that will result in anaphylactic shock or bronchoconstriction, the skin, the itching, or the and other changes in the lungs and the GI tract. So the histamine, we have the histamine receptors, H1 receptor and H2 receptors, and we said that the H2 receptors that are in this found in the stomach, and they are responsible for peptic ulcer disease. So in this chapter, we will focus on the histamine or H1 receptors that are present in the smooth muscles of vascular system and the bronchial tree, and causes many of the symptoms of the allergic rhinitis. So to prevent the allergic rhinitis, we need antihistamines, intranasal steroids or corticosteroids, mast cell stabilizers, and most of that will be delivered as the oral and intranasal decongestants. The antihistamines are widely used to treat allergic rhinitis and other minor allergies. Now, the antihistamines are also often combined with decongestants and antitussives or antitussives, anti-cough medications in the OTC, over-the-counter cold and sinus medications. And more, as we said, that this is all over-the-counter medications that can be taken with no prescription. So the selective H1 receptors, which is H1 receptor antagonist or blocker, we usually use these medications to treat, to relieve the allergy symptoms in motion sickness, insomnia. They are good for insomnia as well, because that will result in antihistamines. They cause or result in patient tend to sleep from taking these medications. So it's a good, it has a use for insomnia. So the pharmacotherapy for allergic rhinitis, the classes, as we said, that we commonly use it for this condition, the oral antihistamines, the intranasal glucocorticoid, and the oral and intranasal sympathetic mimetics. The oral antihistamines, we have first line, which is the first line of management or drug for this condition. They do not reduce nasal congestion. Most effective if taken prophylactically. So it's not after the math or after the, after the condition, or the episode has occurred. It's more of to prevent the incident, the event, or prevent the allergic rhinitis condition or from happening. So it's more prophylactically, we can manage the disease prophylactically, not after it happened. So the H1 receptor antagonist, They are effective, as we said, to treat vertigo, motion sickness, insomnia, and as well, and also we can add to that Parkinson's disease and other skin urticaria or skin rashes. So the H1 receptor antagonist, there is no adverse effect of drowsiness because this drug does not cross the blood-brain barrier. So the first generation drugs or agents, the top two, which is the Estelin, Benadryl, and as we know that Benadryl is the most widely or commonly used drug. The Estelin, which is the intranasal spray, and Benadryl is most likely you'll find it as a tablet. The second generation, which is the Zyrtec or Claritin, Clarinix as well, but the Zyrtec and Claritin most widely used drugs. So the adverse effects are mild. So when we said sedation, that would be mild sedation or drowsiness with the first generation, but much less with the second generation. So after a few doses, patient will develop tolerance to this sedative action. So this sedation becomes, patient develop tolerance to this sedative action or sedation after taking the drug through for a few times or a few doses. The second generation antihistamines has less tendency to cause sedation because they do not cross the blood-brain barrier. The adverse effects with the elderly, CNS, dizziness, confusion, fatigue, the anticholinergic effect, dry mouth, due to dry mucous membranes, urinary urgency, especially for those who have the BPH. The prototype drug for this is diphenhydramine, which is Benadryl. We have also another drug called Allegra that's similar to this drug. So I'm going to skip a few slides and just highlight the most important things that are not listed here in the slide. The Benadryl is often combined with an analgesic, with decongestant or expectorant to to expel the or remove the secretions out or to expel the secretions, and that will be in combination with these drugs as an OTC drug, as a cold remedy, and for flu product. And it's usually administered the Benadryl topically to treat rashes, can be given IM and IV also for severe allergic reactions. When administering the drug IV injected at a rate of 25 milligrams per minute to reduce the risk of shock. When given the drug IM injected deep into a large muscle to minimize skin irritation. Benadryl, these are some of the side effects, but also it may cause, as we said, dry mouth, tachycardia, mild hypotension, and in addition to also the photosensitivity. And the drug also should be shown contraindication to should be used cautiously in patients with asthma or hyperthyroid. In terms of drug-drug interactions, it may interact with MAO inhibitors, the monoamine oxidase inhibitors, because it may cause a hypertensive crisis. So the drug should be, in terms of lab tests, should be discontinued at least 4 days prior to skin allergy test. Otherwise, there will be a false negative result from after taking the test while being on Benadryl at the same time. The nursing responsibilities. So we will obtain the history, patient history, and use caution in patients with the dysrhythmias or history of dysrhythmias, heart failure, hypertension, because these drugs can cause vasodilatation. So patient and family education, you add to what we have on the slide. Also, the stop taking the medication at least 4 days prior to skin allergy, which is, we just mentioned that because that will result in a false negative readings of the test. These are some examples of antihistamines, decongestants, and analgesics, or in other words, the combination drugs or antihistamines with decongestant with analgesics combined together in one drug. Intranasal corticosteroids. Prototype drug is fluticasone, which is Flonase, very common drug, very effective in treating the allergic rhinitis. Adverse effect is nasal irritation, epistaxis, which is bloody nose. Intranasal corticosteroids, which is a Flonase, the intranasal Flonase, the mechanism of action of this drug that it decreases the secretion of the inflammatory mediators like cytokines, leukotrienes, and histamines, and so this drug has joined antihistamines as first-line drug for treatment of allergic rhinitis. It reduces the tissue edema. It will cause mild vasoconstriction. And all these agents are the nasal corticosteroids or steroids nasally, intranasal like the Flonase. They are delivered via the this drug will be given or administered through that metered spray devices. The spray devices that are metered doses, and the peak effect or response of taking these drugs will be evident or shown in like 1 up to 3 weeks. The mild adverse effects of that will be the dryness of the nasal mucosa or the sore throat, the intense burning sensation in the nose immediately after spraying. That's another side effect. The Flonase, as we said, it's the treatment, so symptoms associated with seasonal or allergic rhinitis, prolonged use may lead to tolerance to the lungs, to the drug treatment effect. So, which in other words, that the patient may develop tolerance with the prolonged use of this drug. And this drug is available as oral inhalation, like Flovent for asthma and COPD. It's also, we can get it as a topical ointment for eczema, for psoriasis, for contact dermatitis, and in terms of patient and family education, other than shaking the inhalers gently before spraying, avoid swallowing the medication, and to administer the decongestant first if used concurrently with this drug. So when you expect that patient is taken, or you teach the patient that they have to administer the decongestant first, if the decongestant is taken as a separate medication with the Flonase. Next topic, which is the common cold. Which is another acute upper respiratory viral infection. No cure for, there is no cure for this, but just the treatment of the symptoms. We try just to cover the symptoms and to relieve the symptoms without treatment of the underlying cause. It's a self-limited disease and usually benign, well tolerated among all age groups and individuals. And these are some of the remedies and medications that we take for the common cold. There's the decongestant, antitussives, analgesics, antihistamines for allergic, cholinergic actions, and caffeine. That's to offset any effect of the antihistamine. So decongestants, that's a oral or nasal remedies or medications, most effective agents to relieve the nasal congestion. And the resultant of this vasoconstriction of the nasal mucosa, which will lead to the shrinkage of mucosal swelling. It will relieve the swelling of the mucosa and the nasal mucosa. The activations of the beta-2 adrenergic receptors will cause some bronchodilation. And that's usually or often combined with antihistamines in the treatment of allergic rhinitis or common cold. The rebound congestion from most of that will result from the intranasal preparations. That is one of the side effects. The most frequent or common side effect is rebound congestion. So that's why it should be used only for 3 to 5 days to prevent dependence and switch to a different intranasal corticosteroid. Oxymetazoline, which is the prototype drug, the Afrin, for this classification or drug classification. The rebound congestion, when the Afrin is used for longer than 3 to 5 days, that would result in the rebound congestion. The rebound also, this drug is also available as a eye drops. It will cause vasoconstriction of the vessels in the eye, and it is used to relieve redness and provide relief from dryness and minor eye irritations. So the administration alerts, that's, wash hands carefully after administration to prevent anisocoria, which is the blurred vision and inequality of the pupil size. Blurred vision and inequality of the pupil size. The adverse effects, we have systemic adverse effects that are unlikely. So this is not very common unless the patient takes like a large amount of medication. It's like swallowing the medication. So it's not common unless the patient takes a large amount of the medicine is swallowed. The contraindications, patients with thyroid disorders, hypertension, diabetes, heart disease, they should use these drugs only on the direction of the healthcare provider because of the vasoconstriction effect. Cromolyn and montelukast, which is the common drug is cromolyn and also the singular. Now the singular is, or montelukast, which is a singular, very common, very widely used drug. So that's an alternative to using these intranasal corticosteroids in the treatment of allergic rhinitis. So these are mast cell stabilizers. They will inhibit the release of these chemical mediators, these inflammatory mediators like histamine, leukotrienes, and others, prostaglandins as well. So the intranasal cromolyn, which is the nasal crom, safe drug. It has moderate effect compared to other, like singular, for example. Best used for prophylaxis, not for treatment. And the response may take up to 1 to 2 weeks to develop. Pseudoephedrine, like Sudafed, that's a tablet or elixir formulations. And the off-label use for this one to prevent otitis, barotrauma during the air travel or driving. So as the starting chemical for the synthesis of illegal methamphetamines by drug traffickers. So the pharmacist usually, they should keep a log of patients' names and addresses and IDs when that's the law. I mean, in terms of that's, and we have to be compliant with this, is that the pharmacist should always, any Sudafed purchased has to be documented, and the pharmacist should keep a log of the patient's names, addresses, and IDs. So the contraindications for the pseudoephedrine, which is Sudafed, and precautions and contraindications should not be used for patients with severe hypertension, coronary artery disease, CAD. Also should be used in caution in patients who take or on the monoamine oxidase MAO inhibitors and patients with BPH. Antitussives, which is the drugs that suppress the cough reflex. We can take, or patients can take, the opioid antitussives or non-opioids. And we have examples of each. Next slide is providing some of the examples of the selective antitussives, expectorants, and mucolytics. Antitussives, anti-cough, expectorants to expel that and remove these secretions out, cough these secretions out and expel them out. And then mucolytic is to liquefy the secretions, make it less thicker so that it will be easily can be expectorated or can be suctioned. Like a mucomist, for example, that's acetylcysteine, one of the drugs that is our mucolytics. And we said that we explained that the acetylcysteine in class, that acetylcysteine mucomist is a drug that has multiple uses other than just being mucolytic. We said that we use mucomist or acetylcysteine as an antidote for acetaminophen, Tylenol overdose or toxicity. We can also give it to patients who tend to have renal impairment and anticipated to undergo the diagnostic testing using or with the use of the contrast media. So to prevent the further renal damage or impairment, we will recommend or prescribe or encourage that patient take the mucomist to preserve that renal function due to the use of these chemical, con contrast media. So the antitussives, these are the drugs that suppress the cough reflex. And they are contraindicated and should be used with caution in patients with liver impairment. The drug interactions, patients with or on taking the MAO inhibitors, triptans for migraine or SSRIs should not take the drug, and due to the risk of serotonin syndrome. Serotonin syndrome or crisis, that's when the patient will have a change of blood pressure, confusion. These are some of the signs and symptoms. The dextromethorphan, like Robitussin DM or Robitussin, Dilslime or Robitussin, it has a rapid onset of action. Usually within 15 to 30 minutes. And that's like the codeine, for example. It acts in the medulla. Although it lacks the analgesic and the analgesic effect of the opioid, like codeine, which is an opioid, although it has the same effect on like the codeine on the medulla, it lacks the analgesic effect of the opioid, and it doesn't produce any dependence. However, the codeine as an antitussive, it may result in, or cough suppressant, it can result in e dependence because that's an opioid drug, the codeine. So here in the adverse effects in abuse situations, the drug can cause CNS toxicity with a wide variety of symptoms, such as the slurred speech, ataxia, respiratory depression, seizures, coma, coma or toxic psychoses. Drug-drug interactions, if the drug is used with alcohol, opioids, or other CNS, it may result in sedation. Pneumonia, the last topic in this lecture is pneumonia. Which is the acute inflammation of the lung parenchyma that is most frequently caused by the microorganism. So there is a microorganism that would cause the pneumonia. So previously, the leading cause of death in the United States from infectious diseases. However, that the discovery of the sulfa drugs and penicillin had decreased that morbidity and mortality rates from this disease. So the etiology, normally so decreased cough and epiglottal reflexes may allow or lead to the aspiration, That's why, sometimes, like elderly who have a difficulty, swallowing, they have dysphagia. Sometimes, they do aspirate, and then that will result in pneumonia. So they call that, and then we call this aspiration pneumonia. So normally the airway distal to the larynx is sterile because of the protective defense mechanisms. So these mechanisms include filtration of air, warming, and humidification of the inspired air. And these are the mechanisms that will be that might be impaired, or in other words, the factors that may impair these mucociliary mechanisms that are defense mechanism, or as part of the defense mechanism that will prevent the pneumonia. So these are the factors that may inhibit these and impair these mechanisms, like pollution, tobacco, cigarette smoking, infections of the URIs, upper respiratory tract infections, tracheal intubation. Also, there is a risk that patient may develop pneumonia after being intubated. Age as well. So elderly at some point in on the nursing homes, sometimes we, we should be careful when we feed the patient. So any coughing reflex or any cough that's a sign of aspiration or then or dysphagia, and we have so that's again that sometimes will result in the aspiration and then aspiration pneumonia. Altered oropharyngeal flora can also occur after a patient has received or taken that antibiotic therapy for an infection elsewhere in the body, like say like they have a UTI and they took antibiotics. That sometimes will alter the oropharyngeal flora due, after status post or due to taking these antibiotics, and which will impair these mucociliary mechanisms. These are the three ways or mechanisms or that these organisms will enter the lungs and cause pneumonia. And these are some of the microorganisms. Now, there are too many or different types of pneumonia. The first one is called CAP, which is community-acquired pneumonia. That's when the lower respiratory infection of lung with, so it's the infection of the lower respiratory tract with. That's when the onset of this disease takes place in the community or during the first 2 days of hospitalization. So if this disease had happened or took place in the community prior to or before being admitted for admission, or during the first 2 days of hospitalization, that is called community-acquired pneumonia. It's the highest incidence in a midwinter time or season. Also, the smoking is an important risk factor for this type. HAP, which is hospital-acquired pneumonia, which occurs usually 48 hours or longer after admission and not incubating at time of hospitalization. A risk factor for the HAP, the hospital-acquired pneumonia, like patients who take immunosuppressant therapy, general debility or general weakness, general weakness or debilitation. Patients being intubated, endotracheal intubation. And then the VAP, which is ventilator-associated pneumonia, the VAP, that usually occurs more than 48 hours after endotracheal intubation. HCAP, HCAP, which is healthcare-associated pneumonia, that's a new onset of pneumonia in a patient who, so we have like 4 different criteria for this, who was hospitalized in acute care hospital for or facility for 2 or more days within the 90 days of the infection. Patient who reside in a long-term facility like a nursing home or assisted living, patient who has received an IV antibiotic therapy or chemotherapy or wound care within the last or the past 30 days of the current infection, or patient who attended a hemodialysis clinic, was taking or under the hemodialysis treatment for end-stage renal disease, ESRD. And we have also the aspiration, last, which is one of the last two different types of pneumonia, which is one is opportunistic and then the aspiration. The aspiration pneumonia, that's the condition that would increase the risk of, that would result from the aspiration. So and usually it's because of dysphagia, difficult swallowing, and the conditions that would result in these and the risk of aspiration, and then eventually that, or ultimately the aspiration pneumonia, decreased level of consciousness, seizures, being on anesthesia, head injury, stroke, alcohol intake, difficult swallowing of any type, and nasogastric intubation with or without tube feeding. All of these are factors that may result in aspiration and then aspiration pneumonia. So it's usually a condition that will will occur or take place in patients with a history of loss of consciousness. So the condition that is significant in this scenario or this aspiration pneumonia is the loss of consciousness or the change of consciousness or alteration of consciousness. And that's because of the effect of when there is a loss, especially with the loss of consciousness, like patient become unconscious, there will be the suppression of the gag reflex and the cough reflex. So patient cannot swallow, patient cannot take care of these secretions. So the gag and cough reflex, when they are suppressed due to being unconscious, that is the key why patients develop the aspiration and aspiration pneumonia. These are the forms of aspiration pneumonia. And then the last one we have the opportunistic pneumonia, and we did explain in class briefly, went over this, and we said that opportunistic pneumonia, that's patients at risk would be the patients who are severely malnourished, severe protein calorie malnutrition, immune deficiencies like HIV/AIDS patients, for example, patients on chemotherapy and radiation therapy, patients who are recipients of this chemo or radiation, they will be at risk for opportunistic pneumonia. Patients on long-term steroid therapy, corticosteroid therapy, also will be at risk. And we did explain these, these specific, causes like the PCP or pneumocystis jirovecii pneumonia or PCP, cytomegalovirus, fungal infections, bacterial or viral agents. See, these are the exact causes of this disease or of this specific type of opportunistic pneumonia. So here is the pathophysiology of pneumonia. Clinical manifestations. The confusion or stupor that may be manifested in the older adults that's usually related or possibly related to the hypoxia. Complications, pleurisy, that's the rubbing of the two pleural and parietal linings around the lungs against each other, so that will result in severe pain with the inhalation. Pleural effusion, which is develops usually in about 40% of hospitalized patients with pneumococcal pneumonia. Atelectasis usually clears with cough and deep breathing. Bacteremia, which is in other words, that's the sepsis or septicemia, most likely will result in pneumococcal pneumonia. Lung abscess, usually the gram-negative pneumonia result in the lung abscess. Empyema, which is the pussy secretions, the pus exudate drainage, which requires the antibiotics, definitely. So pneumococcal vaccines, which usually should be given once every 5 years. And we have a specific guidelines and criteria for who should receive the pneumonia vaccines. These are the antibiotics or the medications for the pneumonia. And we covered this in the other chapter of the antimicrobial drugs.